So neoplasia in lungs is a very vast topic. So if we take a look on the historical from the WHO classification point of view, so WHO has already been classifying all of the pathology, the tumor that are available in humans. WHO has a vast experience in classifying the pathology of tumor. This include the lung pathology with the experience and data of more than 50 years. So this topic is a bit laborious to be presented. However, we will try to simplify as much as possible in this lecture. So first of all, we take a look on the WHO classification for lung carcinoma or lung tumor. So there's a very vast classification that have been introduced by the WHO, and in each edition of WHO classification of tumor, there will be some updates and changes in their classifications, and sometimes the tumor or the malignancy had been switched or replaced by something else, and this process will be continue in the future. So, but however, the basic what we need to understand is there are some basics classification of WHO. So if you take a closer look, you can see that WHO has classified tumor into a few types based on the tumor differentiations. So if you take a look of the list, it is very long list of lung tumor. So this will make the lectures a bit difficult to cover each of the topics in details, but we'll try as much as possible to try to cover the most important essence of these classifications, right? So how to approach is, number one, is there one rule fits all? No, actually you should abolish these things, because there is no one rule fits all. So you can use your own algorithm, you can use your own rules when you are practicing afterwards, because there is no one rule fits all. So for the purpose of making diagnosis is to classify the tumor, to make diagnosis for the patient treatment. So algorithm here can be anything. You can create your own algorithm. Do not constrain yourself to the previous kind of algorithm that have been introduced to you by your senior or your lecturer during your studies. So algorithm can be anything, but it must has a base of the algorithm. So in this case, what we base on is the WHO classification of tumor, so that we can classify the tumor cases that we receive, and make a diagnosis for a patient treatment, or the outcome is for the patient treatment in the future. Okay, a little bit that you need to do self-study on is to explore on the clinical management for for the lung pathology or lung tumor, the molecular pathogenesis of it. I won't touch it about this, and I won't talk in detail because it's a very laborious topics, and it requires a lot of time, a long time to understand and to explain it regarding it, because molecular pathogenesis is a very um, is a very depth kind of topic that we need to sit down, talk about it, and have a look at the research that have been done, that have been going on afterwards. For the molecular classification, there's also a lot of school of thought regarding molecular classification. You can have a look at it and also understand that there are a lot of molecular classification, and this classification will help you in managing the patients afterwards. Alright, so we go on directly onto the classification. I will share with you some of the images and explain as we go along in this lecture. Alright, for lung tumor, based on WHO 2021, so it is divided into a few sub category. Number one is for epithelial tumor, neuroendocrine tumor, mesenchymal tumor, hematolymphoid tumor, ectopic tissue tumor, and these are the 5 main tumor that have been discovered and have been classified for the lung tumor. For epithelial, it can be further divided into few category. Number one is a benign tumor, which consists of papilloma and also adenoma. The next one is the precursor lesion for adenocarcinoma and also precursor lesion for squamous cell carcinoma. And the last one is the malignant counterpart of the epithelial tumor, which consists of adenocarcinoma, squamous cell carcinoma, large cell carcinoma, adenosquamous pleomorphic sarcomatoid, salivary gland, and other few subclassification for epithelial tumor. The next one is neuroendocrine. So it starts with, again, precursor lesions. There are no benign lesion for neuroendocrine, so they start directly with the neuroendocrine tumor, and then neuroendocrine carcinoma, which consists of small cell, large cell, and a few other type of pathology that are considered as neuroendocrine carcinoma afterwards. The mesenchymal tumor is another classifications that cater on the mesenchymal part of the lungs tumor. So this I won't touch in detail getting this one because it's a bit technical and controversial to discuss on. For the hematolymphoid, also I won't touch any, not much. I won't touch getting hematolymphoid. Why? Because the hematolymphoid is almost the same with other hematolymphoid tumor that occur not inside the lymph nodes or nodal hematolymphoid tumor. So because it's almost the same, you can have a reference, you can have a look at the WHO categorizations of the tumor, hematolymphoid tumor that occur in the lung, and have a look on the detail on the pathology of hematolymphoid, each of a hematolymphoid tumor in the hematolymphoid topics. For ectopic tissue, also almost the same. The melanoma is similar that occur elsewhere in the body, and also the meningioma is almost the same. Alright, first we go to the papilloma versus adenoma. This is the what we say the epithelial part of the tumor. So again, papilloma is, what is papilloma? It's actually it's projections, tumor projections, a tumor that formed by exophytic growth. Sometimes we describe it as nipple-like or sometimes finger-like projections, so that because it resembles the finger or the nipples. So if you take a look at this finger diagram over here, or the hand diagram over here, I make a simple annotation. So if you cut the hand like that, what you will see is there will be a circle like that. Alright, 4 circles, and the blue part here is usually the skin that covering the finger, and at the center you have the bones and also soft tissue that are inside there. Okay, so that is how if you make a cross section of finger, you will see like the features like this one. But if you cut the finger longitudinally, what you will see is the finger will be like this one. The skin is in a longitudinal shape, and the bone is at the center here. So this is how does the finger or the papilloma looks like. So the different way you process or cut the specimen, you will see a different kind of structure inside underneath the microscope. So this is just to orientate you a little bit on the papilloma. So number one, the most common papilloma that occur in the lung is the squamous papilloma. So the squamous papilloma is usually occur in the bronchioles, the large airway, and it looks like some sort like this one. So all of these are the squamous epithelium, whereas this pinkish island of pinkish cells over here with a lot of vascular spaces here and there is the stroma of it, the center of the papillary projections. Why does it happen to look like this island of cells instead of a nice looking papillary projection like this? This is because papillary or papilloma does not always have a nice finger-like projection or nice finger-like structure. It is usually looks like a cauliflower. So you see in the cauliflower, the surface of cauliflower, there's some ridges inside here, some are protruding out and some are going inside. So if you cut the cauliflower straight like this one, so you can see there's some island of the part of the stem here and there in the cross sections. So that is why papillary squamous papilloma look like this. Different from squamous papilloma, and adenoma is actually a benign tumor of epithelial in origins, and it formed by a glandular structure, or glandular is arises from the glandular origins, or it formed by a glandular structure. So in alveolar adenoma, you can see that this is the lesions, whereas the rest, the downward part over here is the normal alveolar spaces, the normal lung parenchyma, which consists of a lot of alveoli. So the alveolar adenoma over here is mainly formed by a gland forming tumor. That is why we call it adenoma. So if anything names adenoma, so you should see gland forming or glands inside the lesions. So to make a diagnosis of adenoma, the first one is you need to see the gland inside the tumor itself. So apart from that, these glands should be lined by benign epithelial cells instead of malignant or any kind of dysplastic cells. It's really a benign kind of epithelium. There's no pleomorphism, there's no increase in mitosis, there's no necrosis. Just a simple benign epithelium. It could be cuboidal epithelium, it could be columnar epithelium, but the first thing to see is it is a benign epithelium. No pleomorphism, no necrosis, no increase in mitosis. So that is when you say that this lesion is adenoma, because as the name implies, oma means it's a benign lesion, right? So before any cancer can occur, there will be a precancerous or precursor lesions. So this precancerous or precursor lesion will have a potential to further develop into a carcinoma or malignant epithelium. For example, in this atypical adenomatous hyperplasia, if you compare the small picture over here is the normal alveoli. So there's a lot of alveolar space. So what does the epithelial lining of the alveoli? So it is a simple squamous epithelium. So for the picture, underneath here is the atypical adenomatous hyperplasia, and you can see the lining epithelium is a bit hyperplastic, so increase in numbers and size, and it's a bit atypical. So there are some cells which are small, like this one, small cells, and also there are present also the lining of a large cell like this one. So when there is a discrepancy between these cells, means there's a presence of small cells and also large cells, we call it pleomorphism, or sometimes you can say atypia or dysplasia or dysplastic cells. Right? So when there is a discrepancy between, there's a lot of variability within the lining cells or the cells within the tumor, means that there's a variability in size and also variability in shapes, because you can see this one is a bit rounder, this one is irregular shape. So when there's a variability in size and shape, we call it pleomorphism, atypia, or dysplasia. So then this is one of the precursor lesions that will sooner develop into adenocarcinoma of the lung. And majority of adenocarcinoma of the lung does not related with cigarette smoking or any exposure of the toxicity substances that are, or carcinogenic substances from the atmosphere, but rather it is usually occur due to mutations in the genes. There's a lot of mutations in genes, so you can have a look and list down all of the genes that are possible to cause mutations in adenocarcinoma of the lungs, right? So because of these mutations, the lining epithelium of the alveolar, which previously or normally are lined by the simple squamous epithelium, it will change into adenocarcinoma or adenomatous or glands-like epithelium, which could be cuboidal or columnar kind of epithelium. So when this happens, so the patient is already has or have atypical adenomatous hyperplasia or the precursor lesions of adenocarcinoma of the lungs. Similar cases with the squamous cell carcinoma, there are also precursor or precursor lesions for the squamous cell carcinoma, and the name of it is the severe squamous dysplasia. So there are dysplasia. Remember again, when there's dysplasia, there's a variability in size and shape of cells and also nucleus of cells, and there are also some other features that suggesting that this is a squamous epithelium. To identify it, the squamous dysplasia is usually looks like a squamous or the epithelial lining of the epidermis of the skin, or we call it the epidermis. So it's almost the same like epidermis lining. There are some maturation, degree of maturation is there, but the cells that the lining of the squamous that are present in these bronchioles or trachea is abnormal, or abnormal, because as you know, the lining of the trachea and also the bronchiole should be pseudostratified columnar epithelium with cilia, like in the picture over here. So when there is an exposure of these cells to cigarette smoke or any kind of a toxin or any carcinogenic agents, so these cells will transform into these cells. So it's from pseudostratified squamous, pseudostratified columnar, ciliated columnar epithelium, it will transform into a squamous epithelium. This is because squamous epithelium is a very harsh and very tough kind of epithelium that can withstand the insults of toxin or cigarette or smokes that are coming from the atmosphere or from inhalations by the patient or the person itself. So it will change itself into a squamous, and by time it will, from the squamous metaplasia, it become dysplastic, and severe squamous dysplasia is a precursor lesion of the squamous cell carcinoma. And for the adenocarcinoma, after the patient develop into or has the atypical adenomatous hyperplasia, sooner or later the lesion will transform into invasive adenocarcinoma. So the features that telling us that this adenocarcinoma or this lesion or this tumor is invasive is the presence of the surrounding desmoplastic stroma. So I will show to you later in the slides how does a proper or nicer desmoplastic stroma looks like. But in this picture, I just wanted to highlight to you that to make a diagnosis of adenocarcinoma, so adeno is gland forming, carcinoma, gland forming carcinoma. So adenocarcinoma is a gland forming carcinoma. So how does you identify that this case is an adenocarcinoma? Very easy. You need to understand what are glands. So glands, it should be, number one, has an epithelial lining. Number two, has a lumen. So where are the glands inside here? So this is one gland. So in between the blue and also the green line here is the epithelial lining. And where is the lumen? The lumen is here. At the center here is the lumen. So when there is a presence of epithelial linings and also the lumen, so you will be certain that this is a gland forming tumor. So how to say that it is a carcinoma? To say that this is a carcinoma, number one, what you need to see is the pleomorphism. Number two is mitosis, is if there is any. Number three is necrosis. And number four is the desmoplastic stroma. So when there's presence of this thing, so it conclude that this tumor is a carcinoma or malignant in nature. Alright, here is another photomicrograph that's showing to you extensive desmoplastic stroma formations. Don't worry regarding the term, because desmoplastic stroma is actually increase in the fibroblast and fibrocytes formations surrounding the tumor cells, right? So this is because the tumor cells stimulates the production of the stroma surrounding it. There's no clear reason why, but this is the pathophysiology or the function of the some precursor released by the tumor. So this precursor will increase or stimulate the fibroblast productions, and this will cause the formation of the small plastic stroma surrounding the tumor cells. All right, for squamous cell carcinoma, this tumor is actually formed by a kind of malignant tissue or malignant cells that transform itself or originate. It's not originated, it's transformed from a benign linings into a squamous dysplasia and currently transformed into a squamous cell carcinoma. So as you see in this picture, the overlying tissue over here, or the lying linings over here, is the pseudostratified squamous pseudostratified columnar epithelium with cilia, which is the normal linings of the trachea or the bronchus. Ambulance, okay. So again, I don't know why. So for regarding the squamous cell carcinoma, it is a kind of tumor that transform or differentiate into a squamous cell kind of a epithelium. So that's why the name implies a squamous cell carcinoma. As you can see in this picture, the overlying structure or overlying tissues here is still the respiratory epithelium, which is the pseudostratified columnar epithelium with cilia. But underneath here, you can see that there is a invasions by the malignant tumor, which this is the squamous cell epithelium. So I will further show you in detail on how to recognize that these cells is actually the squamous cell carcinoma. Alright, so at this point you can see that there's invasions by a malignant cells inside the stroma of the within the stroma of the trachea or bronchus. So in this case, I think it's most probably the trachea. The terminal bronchioles, because there are no cartilage seen adjacent. Right. The most important thing is to identify that this cell differentiates itself into a squamous cells. So number one is the presence of the keratin pearls. So what are keratin pearls? Is actually the keratin productions by these squamous cells, malignant squamous cells, because it cannot produce the keratin outwards or externally, or towards the lumen or towards the surface of any kind of lining. So the keratin that are produced by this tumor is entrapped within the tumor tissue itself. So by time it forms sort of a circular lamellated kind of a structure, same as the pearl. So this is a pearl. Actually, if you take a pearl and cut it through its center, so you will find pearl layering like this. So that's why we call it a keratin pearls. So this is one keratin pearls, this is another one, and adjacent here is another one keratin pearls. So apart from keratin pearls, the most important thing, or the most important structure that you need to see or to identify in order for you to say that this tumor is actually a squamous cells, differentiate itself into squamous cells. So the structure that you need to see is this kind of this structure, in which this structure, this is what we call intercellular bridging. So because this structure bridges in between one cells to another cell. So for example, in this picture, this is one squamous malignant squamous cell. This is the nucleus, the center here, and this is another malignant squamous cells. These are two nucleus inside it with a prominent nucleoli. So this structure, in which extend from the cell membrane of these cells into the another cells, is what we call intercellular bridges. So it extends in between from one cell membrane to another cell's membrane. So this structure is what we call intercellular bridges. So this kind of structure is very how is it? It is a very is a most important features of a squamous cells carcinoma. Next, for the large cell carcinoma. So the large cell carcinoma is a type of carcinoma epithelial arising from the epithelial cells, but it does not have or has any kind of a differentiation. So it does not has any adenocarcinoma features, and it also does not have any squamous cell carcinoma feature. So it does not have any kind of a differentiation. It just some sort of large cells happen to be found inside the lung parenchyma. So the most important thing is to identify, to say that this is a large cell carcinoma. Number one, you need to exclude all of the adenocarcinoma features. There are no tubular formations. There are no glands forming tumor. Number two, you need to differentiate. You need to exclude all of the squamous cell carcinoma features. Means you should not see any keratin pulse. You should not see any intercellular bridges that can point towards squamous cell carcinoma. If there is any of these features that are present inside the tumor, for example, you exclude the adenocarcinoma features part, but in the part of the tumor, you can see most probably there's some keratin pulse formation. So this tumor cannot fall into large cell carcinoma. So this tumor is actually a type of squamous cell carcinoma, in which it is most probably poorly differentiated. So that's why the tumor is still has preserved their squamous cell differentiations. But if you do not found any adenocarcinoma features, and also do not found any squamous cell carcinoma features, so then this tumor falls into large cell carcinoma. Alright. Another subtype is of epithelial carcinoma is the adenosquamous carcinoma. So adenosquamous carcinoma is actually the mixture between the adenocarcinoma and also squamous cell carcinoma. So there are two features in one tumor. So the most important thing, the sweet number to say that this is a mixed kind of a tumor is 10%. Means in a predominantly adenocarcinoma tumor, there are 10% or more 10% or more part of the tumor shows squamous cell carcinoma differentiation, or in a squamous cell carcinoma tumor, 10% or more shows adenocarcinoma differentiation. So they need 10% of the features to say that this is a mixture of adenosquamous carcinoma. Alright, the rest is the same. The keratin pulse is the same. The tubular formations is the same. The atypicality of the tumor is also the same. So the difference is the presence of the different type of carcinoma inside one major tumor. Alright, next for the neuroendocrine tumor. So neuroendocrine tumor can occur anywhere in the body. It starts from the pituitary, from the endocrine tissues, up to the lungs, to the pancreas, to the GI tracts. So almost all part of the body can express or can differentiate into the neuroendocrine tumor. So for the lung, it is especially can be seen in the bronchus. So what are important things to see in the neuroendocrine tumor? Number one is the tumor is rarely show really a marked pleomorphism, except for neuroendocrine carcinoma. But for neuroendocrine tumor, in which it is still considered as malignant, but it's a much more sort of a lower grade compared to the carcinoma counterpart. Number one is the presence of the coarse chromatin. Okay, you can see this is one nucleus, and you can see there's a lot of black spot inside the nucleus. So that is the coarse chromatin that are present within the nucleus of the tumor. Number two, there's a lot of this kind of tumor is a highly vascularized tumor. So there's a lot of blood vessels in between or inside that are formed inside the tumor. Why does this happen? Is because this tumor is neuroendocrine. So what are the most important thing that you can see in the endocrine structure or endocrine tissue is the presence a lot of blood, because endocrine organs or endocrine tissue secretes hormones into the blood vessels or into the blood. So it needs a lot of vessels inside the tissue. So it is similar with neuroendocrine tumor. So they will stimulate the production or formations of neovascularization so that they can secrete the hormone that they are producing into the blood. So this kind of tumor is usually highly vascularized tumor. And some of the features that are very that can be seen in the neuroendocrine tumor is the presence of rosette. So rosette is like as the name implies, rosette means rose-like structure. So if you search for rosette cookies, so this is what rosette cookies look like, because this kind of cookies look like the mold is sort of a rose-like kind of feature. So this is rosette cookies. So it's actually more resemble of a rosette cookies instead of a rose, a real flower kind of features. So it's more a rosette cookies. So this is how rosette looks like. Right? So the site is usually in trachea. It can be in lobar bronchi, 85% of it, and bronchioles, the terminal bronchioles in around 15% of it. So the diagnostic criteria is it should be more than or equal to 5 millimeter in size, but the mitosis is very low. It's less than 2 mitosis per 2 millimeter square field, and there should be no necrosis. So no necrosis. So growth pattern can be any organoid, trabecular, rosette nested, pseudoglandular, and subpapillary. So this neuroendocrine has a lot of variability in the growth pattern. For the neuroendocrine carcinoma, so it is another counterpart of the neuroendocrine tumor, in which the neuroendocrine carcinoma is for sure 100% malignant. It's usually showing high-grade features. The mitosis is increased, the nucleoli is very prominent, and also there is extensive necrosis going on inside this tumor. Architecturally, the tumor can be in a nest, anastomosing trabeculae, or rosette-like structure. So the basic kind of architecture is still preserved in this neuroendocrine carcinoma. So these are a few features that can be seen inside a neuroendocrine carcinoma. So it can be any kind of features. This one still have a rosette kind of features, same as here. So there's some rosetting going on, but it's not that as nice as you can see in the neuroendocrine tumor. But in this case, in this picture over here, you can see there's a variability in size and also the shape of the tumor, in which that indicates there's a moderate to marked pleomorphism. All right. Just a little bit. I think I will end regarding the WHO classifications related tumor lung pathology. Lung pathology, especially for the neoplasm part. Just a little bit on the non-small cell lung carcinoma versus small cell lung carcinoma. So this is actually a way to classify lung tumor. Classified lung tumor. Alright? So that classification, you need to have a read regarding it, because there are some differences between the non-small cell lung carcinoma and also the small cell lung carcinoma. So maybe if you already have a read regarding that, we can have some discussion, or you can ask me regarding that topics afterwards. By that, thank you, and wish you all the best for the posting.